Thank you for coming this afternoon. I'm Laura Kahn from the Center for Disease Control and Prevention, and I have with me Wendy Blumenthal and Jenny Lunsman, and we're gonna provide some updates and description of the activities that are going on that the CDC is sponsoring here in the Interoperability Showcase. So I'd like to take the opportunity to thank HIMSS for allowing us to come and talk with you today. And hopefully you'll learn some about what's going on in the Interoperability Showcase. So CDC and Public Health has 4 use cases here in the Interoperability Showcase. Can you hear me? Okay. The first use case is called public health reporting, and its demonstration includes both electronic case reporting and vital records reporting with death certificates. And then the second one is the cancer registry discovery and research that Wendy's going to talk more about. And then there's birth reporting, and NICU is demonstrating vital records, both birth and death reporting. And the value-based care use case is demonstrating occupational health data. So in the public health reporting use case, the electronic case reporting activity. So what is electronic case reporting? It's the automated generation and transmission of case reports from electronic health records to public health agencies for review and action. And if you follow this illustration from the top and clockwise, you can see the components of the electronic case reporting approach. It starts with care being documented in the electronic health record. And then if that care matches a set of codes, which are represented here by trigger codes that are LOINC or SNOMED or diagnosis code ICD-10 codes, an electronic initial case report would be generated and sent for decision support. And that decision support can take a look at the information that's in that electronic initial case report and determine where it would be reportable to. And that can often be more than one jurisdiction based on where care was provided or where the patient lives. And that decision support can then generate a response back to the provider in clinical care to say, yes, this was a reportable condition. It was pertussis. It's reportable to the Utah Department of Health, for example, and also allow for the Utah Department of Health to provide information back to that provider to say, this was pertussis. Here's some steps you might want to consider, additional laboratory tests or other information that the health department would want to provide to the provider. That initial case report and that reportability response is also then sent to the public health organization for their case investigation activities. The reportability response also gives opportunity for Utah to ask for additional supplemental information to that initial case report. So that might be more specific information on a condition that is of interest particularly to a jurisdiction, or it might just be disease-specific details that might not be included in the EHR in a way that could be easily gotten out because of the specificity there. So this activity is being implemented through a collaborative called the Digital Bridge. And the Digital Bridge Collaborative brings together EHR vendors, healthcare organizations, and public health organizations in a governance activity, and they are advancing as their first project electronic case reporting. So it's being initially implemented in the sites that you see here: California, Houston, Kansas, Massachusetts, Michigan, New York, and Utah. And as I said, each of these sites brings their public health agency, a healthcare provider, and their EHR vendor. The initial implementations are supporting 5 conditions: pertussis, gonorrhea, chlamydia, salmonellosis, and Zika. And the approach uses existing data and technical standards and is being implemented on a shared infrastructure using the APHL AIMS platform and the CSTE Reportable Conditions Knowledge Management System to do that decision support that I I mentioned. So initial implementations are underway, and we hope to have some lessons learned and see some data flowing the middle of this year. So this is similar to the illustration circle, but shows a little bit more detail about how the flow of the information would go. Just starting there in the, you can see the lanes. At the top lane, healthcare. The middle lane is that shared infrastructure that I mentioned with AIMSS and RCKMS, and the bottom lane, public health. So starting actually in the bottom left-hand corner with public health actually authors the reporting criteria for these reportable conditions into the RCKMS system so that the information in the electronic case reports can be compared to that reporting criteria. As the appropriate codes that are matched to that reporting criteria also provide the basis for the trigger codes, and those trigger codes are provided to healthcare for application in the EHR for matching against the patient data. So when that care is provided, now back up to the top in healthcare, when that care is provided to a patient and the trigger code is matched, it can generate and send that electronic initial case report to the shared infrastructure. There's a validation service on that shared infrastructure to make sure it's a valid document, and if not, we can provide information back on what needs to be corrected with that. If it is a valid document, it's shared with the RCKMS decision support service to compare against the correct criteria and determine if reportability is needed. And again, if that reportability is needed, it can be communicated in the reportability response and sent to the provider for additional information and follow-up, and it can also be sent to public health for their review and action. So now I'm going to pass it to Wendy, and we're going to move on to cancer reporting.
You do that? I'll do that. Thank you. All right. Thanks, Laura. So I'm Wendy Blumenthal. I'm with the National Program of Cancer Registries at CDC, and I'm going to talk about some of the activities that we're doing around cancer registry reporting using electronic health records and interoperability standards here. So just brief background on cancer registries. In 1992, the Cancer Registry Amendment Act, public law, authorized CDC to establish the National Program of Cancer Registries, or NPCR. And what this basically did is make it cancer a nationally reportable disease. It's required by all state laws. So we have population-based longitudinal data that comes from multiple sources on all diagnosed cancers in each particular state. And the information that comes to the state registries includes clinical cancer diagnosis information, treatment, vital status, demographics, and other data. Those are the basic ones. The state cancer registries are a highly standardized data collection system. They have a association called the National Association, NACER. Well, I'm drawing a blank. It's been a long week. So we'll just say NACER, North American Association of Central Cancer Registries. Sorry. NACER is sort of an umbrella organization that enables the state cancer registries and CDC and NCI and other agencies to collaborate on development of standards for the registries. And I think that it's really important. The reason I mentioned that standardization is it's what's enabled us, CDC, to work with the state cancer registries to develop the interoperability standards that we have. Without that, if the states all had different standards, it would make this much more difficult. So here are some of the accomplishments and some of the things that we're demonstrating here today, just down there in one of the use cases. First, we've worked on physician electronic health record reporting. So we have a standard or a profile that we developed in IHE called the Physician Reporting to a Public Health Repository Cancer Registry, or PRPHCA. It's an HL7 clinical document architecture, or CDA-based document. We originally developed that profile and then took that profile. It's a specification, and it also involves some use cases that describe the triggers. So in other words, it describes both the content and the how and when for sending those physician reports to the registries. We took that profile and turned it into a standard that is in ONC certification, and I'll come back to that in a moment. We also developed a newer version of almost the same specification, but a newer, updated version with some new data, content, and aligned with some other CDA documents. We developed that one. That's the second bullet. It's an HL7 CDA implementation guide. So that one was balloted through HL7, and then we made some small updates to it. So the most recent version of that one is a 1.1 HL7 document. So back in 2012, well, we published the guide in 2012, but yeah, so in 2012, we were able to get cancer registry reporting as an optional menu objective in meaningful use stage 2. It was for 2014 implementation. And then for stage 3, it's also an optional item falling under the public health registry reporting umbrella, if you will, and that's for 2018 implementation. So again, these two standards that I mentioned, both of them are two profile specifications. Both of them were published as standards by ONC for certification of the EHRs. The first one for the ONC 2014 edition, and the second one for the 2015 edition. At least 32 state cancer registries are receiving data from physicians using either one of these two formats. CDC develops a software application tool called eMark Plus. It's got a physician reporting module that the states are able to use that module to process these CDA documents, and over 35 states are using that module. It receives and processes those CDA documents, and they can then bring the data, export the data in a format that they need it in for importing into their central cancer registry database. We've also done a lot of work with standards development around electronic pathology and biomarker reporting. We refer to that as EPATH. So we developed an IHE profile for anatomic pathology reporting to public health cancer registry, or ARPH. That's a HL7 version 2 message format. We have 46 state cancer registries receiving live EPATH data. It includes 25 laboratories reporting to those state cancer registries, and over 36 states use the eMark Plus EPATH module for receiving and processing those reports. We also have done work with the IHE structured data capture profile. The SDC profile enables a form-based approach to reporting, and we're using it primarily right now for the College of American Pathologists electronic cancer checklist. So it's specifically, we're using it to allow reporting of pathology and biomarker data to cancer registries. It's currently implemented in the California Cancer Registry, and we have an eMark Plus module for SDC in development. We are demonstrating that SDC transaction or process coming from a EHR vendor that has a pathology module in as part of it, and we're also demonstrating the physician reporting piece. Both of those over in the use case over there. And let's see, last thing. So here's just a diagram to illustrate what I've just described. So one of the key points here, as I mentioned earlier, is that cancer registries receive data from multiple different sources. So this kind of summarizes, as you can see, they can get a report from the primary care provider or specialist, basically a physician that diagnoses or treats cancer, and that would be that PRPHCA content, or what, the implementation guide that's in the meaningful use stage 2 or 3 formats, as I mentioned. So, and that arrow going there to the state public health agency, it says using XDR, so that's an IHE transaction. That's basically a cross-document, I forget what the R stands for, but it's basically a push model of them pushing the cancer report to the state public health state cancer registry, sorry. So then, as you can see, there's also the IHE structured data capture, or SDC. And that's going between, that can be used to go from the anatomic pathology laboratory both to the provider and to the state cancer registry. And then the pathology laboratory can also send that ARPH, which is the HL7 version 2 format of the pathology report. And I should mention the difference between that SDC and ARPH is that the ARPH HL7 version 2 is text-based pathology reporting, which is the traditional type of pathology reporting that's being used mostly today, but we're trying to move, and the College of American Pathologists is trying to move to this more structured data approach using that structured data capture. And I think that covers that there, and I believe that's the last slide.
That is your last.
Thank you.
Great. Thank you, Wendy. I'll spend a little bit of time now talking about the birth and death reporting activity. The National Vital Statistics System consists of provider organizations, local and state vital registrars, and the CDC's National Center for Health Statistics. There's approximately 7 million vital events that are processed annually, with about 4 million births and about 3 million deaths, and about 50,000 fetal deaths. So what's the issue here? The Vital Events Program includes the reporting of demographic, medical, geographic data through birth certificates, death certificates, and fetal death reports. But the process for filing a birth certificate or a death certificate is currently duplicative of other systems or information that needs to be included in those death reports and birth reports are in electronic health records and other medical records. It's labor intensive, it's costly, and it's just not really done very well. And so we're looking to automate this process as well in order to improve this. And the CDC's Division of Vital Statistics has been working collaboratively for a number of years with the National Association for Public Health Statistics and Information Systems, or NAPSIS, with state representatives, with EHR and vital record systems vendors, and with the standards development organizations, HL7 and IHE, to support the eVital Standards Initiative. And the goal of this initiative is to develop and implement national standards to support interoperability, to improve the timeliness, accuracy, and completeness of birth, death, and fetal death records. So this slide provides an overview of the standards that have been developed by HL7 and IHE to support the birth and fetal death reporting. There's more details on each of these standards, both on the Standards Development Organization websites, but also on the CDC's National Center for Health Statistics website. And likewise, this slide includes the standards being used for death reporting. It also includes a new standards development work in the fire space to identify fire resources and profiles to support death reporting, and that this can be used with Smart on Fire apps to provide clinicians with support in determining the cause of death for better death reporting purposes. I'll pass it now to Jenny.
Hi, my name is Jenny Lunsman. I'm with the National Institute for Occupational Safety and Health. We're part of CDC. And our work is actually facilitating the work of our colleagues in public health, but also for other use cases such as clinical decision support. If you think about it, the majority of the adults in the U.S. spend more than half their waking hours at work. So if you're caring for a patient, it might be helpful to know what they're doing the most of their time. Incorporating occupational data for health into electronic health records should be able to help with patient care, population health activities, as well as public health reporting. For example, if you had their work information in electronic health records, you could support public health surveillance and investigations. For example, there was an outbreak of tularemia that occurred on Martha's Vineyard, and it wasn't until later that they realized it was primarily among landscapers. If you had that information ahead of time, you could do preventive work and reach out to landscapers about ways to avoid getting infected. You could also use the information to trigger clinical decision support, such as in the value-based care scenario here at the Interoperability Showcase. You could use it to facilitate recognition by the astute clinician or the care providers when conditions may be linked to occupation and not previously identified, such as recognition of a condition called bronchiolitis obliterans among those who are working in popcorn flavoring factories a few years ago. Furthermore, we've seen examples of care for working populations, such as identifying all house painters in your working population and making sure they have blood lead screening annually, as well as educational materials in their native language so they can avoid being infected and avoid carrying it home to children. Actually, it's the third leading cause of blood lead poisoning in children is take-home exposures from the parents. This is a current model that we have for occupational data for health. It's a little busy because there can be a lot of data. You don't need all of this data all the time. However, we felt it was important to model it all. At the center is the patient, as you can see here, and a record of the person's employment status would be retained over time, as well as data about the person's past and present jobs. That we would like the record to hold their longest held occupation. This is important in particular for cancer reporting. Many cancers have a long latency period and you don't realize that it may have been associated with their work until many years later. Of course, we'd like to know if a person has been retired. That is a self-identified state. We do know people who've been retired twice. So they get to indicate that however many times they have self-identified as retired, but it's independent of their work because you can go on with another job even though you may have been retired from a first career or even a second career. We've incorporated a data element to note that someone has worked in a combat zone because that is also important for care for not only exposures but for mental health issues as well. We've created templates for interoperability that can fit in the social history section of a number of standards. We've coordinated our IHE technical framework occupational data for health, which is shared in the healthy weight profile. And we've coordinated that with some draft HL7 standards that are undergoing ballot. We currently have a draft standard for trial use of a occupational data for health supplemental template for consolidated CDA. We also have a FHIR resource that's been proposed, and we are incorporating occupational data for health in the upcoming version 2.9 messaging standard. So this way, occupational data for health can be used for whatever use case it's needed for, and we're hoping that in the future it will become as fundamental as your age and your weight and your height in your records. One of the examples that you'll see here in the value-based care booth is the use of patient work information for clinical decision support. We gathered subject matter experts that worked with the National Institute for Occupational Safety and Health to prepare knowledge resources with narrative background information and semi-structured logic for recommendations suitable for primary care providers in 3 topic areas. One is recognizing asthma associated with the work environment and managing that condition. The second would be managing diabetes in a workplace that might make it difficult to manage your care. For example, if someone is on a rotating shift, sometimes they're eating at night, sometimes they're eating at day, they don't know how to talk to their care provider about it. Their primary care provider may not know how to address that with their medications. And so providing educational materials both for the care provider and for the patient on how to level their glucose intake. The third topic was writing return to work letters for non-occupation related injuries. So if someone falls off a ladder cleaning their gutters, but they have to return to a job which requires some physical activity, many times the care providers don't have enough information about what that job entails in order to write a meaningful return to work letter. And so the subject matter experts prepared a knowledge resource to facilitate doing that. The diabetes management clinical decision support has currently been shown in the value-based care demonstration. The information is available through the Agency for Healthcare Research and Quality, or AHRQ, CDS Connects repository, and can be retrieved using a CQL, or Clinical Quality Language, and CDS hooks. And I'm going to turn it over to Laura to wrap it up.
So you can see here the contact information for the CDC domain folks for each of these, and I encourage you to reach out to us. We have a little while to entertain questions or discussion, and we'd be happy to do so.
Do the electronic death
I didn't know either.
do the electronic death records now match with other public health registries where people are alive at the time they're in the registry to indicate? I'm thinking of the immunization system, which I know in the beginning they were always afraid to contact patients in case the baby had died between times that they knew it. So is there an interface now with the new electronic death records to some of the other registries?
That's a good question. I am not sure. I know that they have been talking about longitudinal matching from cradle to grave, basically, but I don't know that there is anything in place now that brings in like the immunization registry. Oh, we got somebody with their hand up, so. He's got one right there. Yep.
So for the immunization, for the version 5, 2.5.1 immunization records, there's actually two stages.
Keith, closer. We can't.
There's actually two stages to the immunization registration, and one of them has to do with the patient identification stage, which is an ADT message. The ADT message has always had a field where you could place information about the whether or not the patient is still alive and what their date of death is. The information that's used in the CDA communications for death information contains the same information that would actually be able to go into that ADT message. So public health, if it wanted to, on receipt of the notification of death in the death registry, would actually be able to communicate via the state immunization registries the necessary information in immunization to actually coordinate that. The reality is that you've got 2 or 3 different public health agencies involved at the state level that aren't necessarily thinking about coordinating. So the information models are all there and coordinated and perfectly capable of being able to synchronize that. It's just that there really isn't a singular endpoint that we all communicate to, because I know I would love to communicate to just one endpoint in the state public health system.
Yeah, and I would add that I believe, so all state cancer registries do what they call death clearance. So they do, I think it's every year, they get information on the death index or the death reports for the people in their state, and they match and they link that up with their cancer registry. But again, they're not interfacing live with, as far as I know, currently with that electronic death reporting system. It's more of a once a year linkage. So I think there's definitely some areas for improving the interfacing in the future.
Other comments, questions?
Thanks.
Great.
We got our.
So how have you found the role of HIEs where they exist in terms of either facilitating or making it harder to do some of these things?
So in the case reporting initial pilots, we do have we are working with the Michigan Health Information Exchange, MyHIN. So they are they are the routing and connector, but for clinical care through MyHIN and to the shared infrastructure and back. We're in the process of implementing, but it's a great partner, and we expect that we will have interest in many jurisdictions in using their HIEs as a central hub within their jurisdiction.
And in cancer, actually, Michigan also uses the MyHIN for the cancer reporting. And as far as I know, it seems to be going very well. They are, I believe, in addition to routing it, they also provide some of the validation services as well. Another state, Kentucky, uses their HIE really just for transport, but it does, I think, it's a good model because what it does allow is it takes the burden off of the state registry to try to interact with each of these individual physician providers and then try to set up different transport methods and figure out which ones are going to work. So the HIE, who already have the relationship with those physician offices, can coordinate with them. They can figure out how they're going to get the records, the reports to them, and then they have one single transport method that they use for sending the data to Kentucky State Cancer Registry. I'm sure there are others. Those are the two that I can think of right off the top of my head. I know there are others out there, other models that are either in process or working.
Hi. With reference to the cancer registry, are there standards on how often the provider has to update the information that goes into the registry on a specific patient?
So for the physician reporting and meaningful use, we did identify in the implementation guides, we said that a new cancer CDA report should be sent to the state cancer registry anytime a patient has an encounter with a provider that is related to their cancer. So potentially there could be a good number of reports sent. There were reasons for that. We had a hard time getting consensus. One of the few areas where we haven't been able, where there isn't good consensus across the states with standards. But we had a hard time reaching consensus on one single, or set of trigger points. So that was what we decided to do, and we developed our tool to help with processing that on the receiving end. That's for physician reporting. For hospital reporting, I think it's different. It may vary from state to state, but a lot of them, the hospitals gather all of the information about a patient over the course of their treatment, at least their first course of treatment. So a lot of times they don't send the data until a patient has completed first course of treatment, I believe. I'm a little less versed in the hospital, but that's my understanding. And then pathology reports are sent real-time, immediate pathology, but that's going to be, they could do an addendum or something, but usually you're not going to have multiple updates of the same pathology report very often. I don't know that there's any standards for radiology reporting, not that I'm aware of right now.
Hi, thank you for your presentation. How do you handle duplication of reporting of a particular patient? Do you have a unique patient identifier across, if more than one provider reports into the cancer registry for a particular patient?
Yeah, I don't know. Was that only for me for cancer, or do you want to hear from all of us? Or?
The lab reports as well as the provider reports.
So I can speak to the cancer first, and then in case everyone didn't hear the question, and hopefully I heard most of it, the mic doesn't seem to be that strong, but so it was how do we handle deduplication of information? So in the cancer registries, as I mentioned, there are a number of different sources that can report to a cancer registry, so it is very common to get different reports for the same patient. So state cancer registries have methods in place and tools, including a tool that CDC developed that we provide to the states called Link Plus that performs probabilistic matching. And so, there's going to be different data elements that it matches on, and there's different degrees they can usually set. But at any rate, so we do perform quite a bit of matching, and then they perform what they call what they refer to as consolidation. So merging that information, but picking, if there's discrepancies, picking the best choice for different data elements so that you come up with a single consolidated record. There are rules and algorithms in place for that consolidation so that some of it can be automated. If the rules can't come to a single decision in an automated manner, then they can get it displayed to them for manual review. Does that more or less answer? Okay. I don't know if you want to add.
Yeah, for electronic case reporting, we're obviously early in doing it. We've had some success in learning around electronic laboratory reporting, and the states generally have their own algorithms to handle that. There is no unique identifier across the systems, but I think there's some ways that the HL7 messages can identify that it's an update or linked to or associated with the same report that had been sent but may provide an update. But I think it's a great question, and we'll be learning, and it would be something that will need to be shared across implementations in order to do it consistently.
Yes, before I ask my question, I don't know what your names are. I just see up here, but I don't know who is who.
Okay, I'm Laura.
You're Laura.
Wendy.
Okay.
And I'm Jenny.
Hi, Jenny. My question is, can you, with regards to the cancer reporting, can you kind of tell us what the differences are between hospital registry versus the provider reporting?
So the hospital reporting, state cancer registries have been receiving hospital reporting for a long time. They've been using this flat file standard for a long time, but also hospitals, about 70 or 75% of them are what they call COC, Commission on Cancer Hospitals, and COC hospitals are required to have their own hospital cancer registry. So what that means is that in the hospital, they've got professionals that are trained in cancer registry abstraction, called certified cancer registrars, and they have access to all the data in the hospital, and they do depending on the hospitals, they're all different, but it may be some manual abstraction. But they look at all of the data, and then they are able to actually code and pull together information on a patient that they call a cancer abstract. The hospitals then send that cancer abstract to the state. So the point is that information is already sort of manipulated and massaged by this expert. In physician reporting, we're trying to make use of just what's already captured in an electronic health record system. We're not expecting a registrar trained to do that abstraction. So we're looking for pulling out what's already in there. And so we developed a specification that was designed to work with what's already in the EHR. So for example, in that case, you might have a list of medications that the patient received, like a chemotherapy drug name, and maybe information on the regimen, but we might be able to pull out just the chemotherapy drug name. But we don't have a registrar there saying this chemotherapy was the first course of treatment for that patient. So we just get the drug name, and then on the receiving side, we have to do some manipulation, apply some rules and algorithms to determine that is actually a chemotherapy, and that we suspect, as best we can tell, it appears to be first course of treatment. Does that help answer your question?
So the provider reporting portion, is this fairly new?
Yes. Yeah, well, yes and no. So provider reporting has always been in the state laws and regulations, but as with most public health programs, public health reporting rarely has any teeth, so it's usually, the providers have to, if they don't do it, they may or may not, they're probably not, the state isn't going to be able to do much about it. So some providers have been reporting for a long time, but in some states, they may not have been getting those, or from some providers, they may not have been getting the reports at all. If they were getting them, they could be on paper. They could be, a fax or a PDF or some other non-standard format. Sometimes they send abstractors out to manually abstract the data, but that's very labor-intensive.
The reason why I'm asking is because we're trying to get to the provider reporting, and everyone's not clear on what the differences are between registry reporting, where you have a cancer registrar, and so I'm thinking that what you're saying is, if I have a cancer diagnosis and I'm just going to my PCP just for an office visit, there's value there in submitting a CCD to the state on that encounter.
If you're going to your PCP and they're not the one that diagnosed or are treating you, then no. But if they're the one that diagnosed or treated you, then yes. So where this more likely is going to, the value primarily for the physician reporting is around, the main areas are dermatologists, urologists, medical oncology facilities, gastroenterology, and hematology. I may have missed one. Those are the ones where we know primarily that people are being seen, they're being diagnosed and or treated, and often not being seen in a hospital as well, so there's likely no reports. Now, in some states, like especially in rural areas, from what I understand, PCPs may very well end up being also doing diagnosis of cancers. So I'm not saying the PCP visit isn't relevant at all, but it has to be a visit that is related to the cancer. So if you happen to have cancer and you go to your PCP for, something completely unrelated, then we're not expecting a report to be sent to the cancer registry in that scenario.
I think I know what you're saying now.
Okay.
If whatever provider is maybe treating your cancer currently today, they're getting the staging information from the cancer registrar. They're not getting the other clinical information from the encounter, and that can be that's where the value comes in with the CCD or the CD.
Yeah, there are two areas. One is treatment, like you just described, yes. But also sometimes the diagnosis is never getting reported at all because, so like for dermatology is a common one, unless they send it to an outside path lab. But a lot of dermatology, the diagnosis and treatment is done completely all in a freestanding dermatology office or what have you. And that might not, so there's two areas, missed treatment and misdiagnoses.
Thank you. Now I understand why there's some meaningful use dollars behind that.
Thank you. Great questions. And you really, you put me to the test there, so thanks.
Yeah, we're currently trying to start the provider reporting, so I'm just needing to understand what's the value and the differences. So you have helped me a lot.
Great.
Thank
and if you have more questions about, really, if you want to talk more about implementation specifics, you can come find me in the use case, cancer registry use case down there, and happy to talk to you more if you'd like.
So thank you. So Jenny will be in the value-based care for the occupational health data demonstrations. I'll be in the public health reporting use case in the back. It's green. And Elena, who's not up here with us, is in the birth reporting and NICU site. So come visit us and see the use cases in action that we've talked about. So thank you for attending this afternoon.
Thank you.
Thank you.